Chelsie, it's great to have you again.
Great to be here, Dr. McRae. Love being with you.
Always. So how's it going?
It's going great. So I thought we were going to talk about something else today, but then we had something else come up that I think is going to be really important to talk about. So I had a baby come in today for a tongue tie release. I had previously seen them for a consult, and also the lactation specialist who referred them to me came in, and she said, "Have you heard about this article that just recently came out?" And I hadn't heard about it. So she was fairly, I would say, upset, because there's been a lot that have come out about tongue ties in a negative light. So I looked at it and I actually didn't feel like the article was necessarily negative, because I think there does need to be some management.
So where was the article?
It's on the American Academy of Pediatrics.
So this is a group of pediatricians that have come together. They've looked at and they said, okay, this is the evidence that we've seen. And from the findings, from what you've gleaned, you didn't have a chance. I didn't have a chance. I mean, it's brand new.
Yes.
You've kind of gleaned over it.
I looked over it kind of quickly, because I thought, oh my gosh, what about this? And so I was kind of just looking at it.
Like, what were some of the points that they brought out?
Well, they're talking about how it's becoming overdiagnosed.
And what's your feeling on that?
And I completely agree.
So do I.
With my training with Dr. Chelsie Pinto, one of my favorite things that she says is for every misdiagnosis, there's an overdiagnosis. And so I think that tongue ties, lip ties, buccal ties can absolutely become overdiagnosed, because we have to look at what's normal. And this is exactly what I presented on with you when we were down in Idaho at the Breastfeeding Coalition. We have to establish normalcies. And this comes from my training with Dr. Chelsie Pinto, Dr. Zaghi, Dr. Gahiri. These are providers that establish normalcies. We are meant to have frenula. They are meant to be anchoring points, so they are meant to have some tension. And it takes a workup, a consult, working with lactation to decide if those frenula are in fact causing a dysfunction. Are they too short? Are they too thick? Are they inhibiting the tongue to lift versus, oh, it's tight, release it, especially with the lips. I think the lip probably gets overdiagnosed the most. 96% of babies, research shows, that attachment comes right down to the edge. So that means we would be releasing every baby almost, because it comes right down to the edge.
Yeah, you see it on every baby, just about everyone.
Right. And we're not all walking around with tissue that's still there. As the maxilla grows, that changes.
But there is some when you see it.
Yes.
It is very evident.
Yes.
That it needs to be released. And it's controversial. You and I even think differently on buccal ties. There's ties. Sometimes I see buccal ties. I think I'm going to be in there. Let's go ahead and release it. I don't want it to be a problem in the future. You've kind of steered away from it.
I very rarely do buccal ties.
Right.
And there's some more research has come out with Dr. Baxter, Dr. Zaghi talking about buccal ties. But this is why I work with lactation consultants. I don't want to just see a baby and it's just me on my team. So I look at the feeding assessments. How is the function? That's so important versus what the clinical aspect is. There are sometimes with ties, the tip of the tongue, they're very obvious. But you still need to know what the dysfunction is. I am not a feeding specialist. That needs to be completed by someone who is, with a lactation specialist that knows, okay, they're chomping at the breast, they're compensating, they're taking in air, all those things that help me decide, is this a true restriction, or do they need bodywork? Do they have torticollis? And that's part of what the article is saying as well. There are other things going on. If you have breastfeeding problems, that doesn't mean you have a tongue tie. So lots of different components.
So let's back up. Let's say there's mothers out there that they just had a newborn, or their child's fairly young still, and they're going, I have no idea.
Right.
What would be some of the things that mothers could look to and go, okay, I need an evaluation. They probably got an evaluation from a lactation specialist in the hospital.
Yeah.
But a lot of times mothers are having them at home now and more natural ways. What are some things that a mom could look for if she's just, I really don't know?
Yeah. So look, I went through this myself with my son, and this is what I do for a living. And I was really on the fence about if he had a tongue tie or not. He had a lot of body tension. Um, his jaw was really recessed, pulled back. And so I knew already we had other factors going into it. So if you are a mom and you don't know where to start, you always want to see a lactation specialist first.
Is there types of lactation specialists that they should see?
So the ones that I work with here in Boise, there's a few that routinely work with infants that have tongue ties. They help rehabilitate the function. They can't diagnose, but they understand the symptoms that could be related to tongue tie. So at the breast, they're watching the jaw, the dimpling, they're picking up those things that like maybe they do, and you should see a professional to have an assessment. So finding a good lactation specialist, and I really advocate for anyone who's pregnant finding a lactation specialist before you have the baby, because going through this myself on day 3 when we've lost weight, jaundice, like he wasn't transferring. I thought he was. I mean, you just don't know.
Mm-hmm.
And so thank goodness I had all my resources that I immediately had lactation in day 3. We started chiro and bodywork, all the things. But otherwise you just don't know. And I've had lots of moms come in where you have this weight loss and this problem, and they're just, we're putting on formula, like just get the weight up. And I get it. It's kind of panic, and you just want to feed your baby. I understand.
So a lot of times it's the moms that they're just frustrated. They get frustrated.
It's scary.
It's scary.
Yeah.
They don't feel like they're getting any answers. So that's when find a lactation, and you just look up lactation specialist. If there was somebody that was clear across the country and they needed to find someone, would they just look up lactation specialist?
Yeah. Look up someone in your area or that's near you. My visits were every week. It depends on how often they need to be seen. Is that something you could travel for? It's hard because you don't know who you have in your area, and some are definitely more well versed in signs and symptoms of tongue ties than others. But I would just ask them, is this something you feel comfortable with assessing, not diagnosing, but looking at, even rehabbing after a tongue tie release? Do you work with tongue tied babies? That's what I would look at. And our lactation specialists here in Boise are really wonderful. We're lucky, and they don't just send every baby for a tongue tie consult. They work with them for many, many appointments. I didn't release my son till he was 3 weeks old, and we had lots of appointments. And that's also part of the article that talks about trying non-surgical approaches, which is 100% true.
Absolutely.
You should definitely get in, do body work, do chiro. You don't want to just say everything is due to a tongue tie with breastfeeding, because it's usually multifactorial.
Yes. But then again, on the flip side of that, to say that all tongue ties it's not necessary.
Yeah, 100%.
I mean, because we both have seen that.
Yes.
Where it has been life-changing for mothers.
Immediately on
Yeah.
some. I mean, like this week's been a perfect example. I've had like really quick, and I never guarantee quick results, because we have to rehabilitate a whole swallow and a whole function that this baby developed, starting around 10 weeks in utero. So we have to rehabilitate this function. But this week, it was a great week. We had a lot of really good responses quickly, and it is absolutely necessary in certain situations.
One of the points that the article brought out that you had said, which gets me a little bit fired up, and I wanted to see how you felt about it. They talked about that they did not see, this is the American Academy of Pediatricians, they did not see any evidence that a CO2 laser would be better than scissors.
Or any other
technique.
Right.
I would be happy to go in front of a panel and be able to just tell them and it'd be fairly easy. How do you feel about that?
Well, I use a CO2 laser, so I love it in my hands. I have
Why is
also
that more precise than scissors for the layperson that's going? Well, why would that be different?
So I've taken Dr. Gahiri's course, who is very skilled with lasers. You know, he's a pediatric ENT. He understands, you know, how to use lasers or how to use scissors, the right type of scissor to use. He teaches his techniques, and in the hands of someone who uses scissors, I I think it's a great tool, right? So, but what I tend to see with scissors, and this is not every provider, but just in general, they might clip the thin webbing in more the front, and they're not fully uncasing, as Dr. Gahiri calls it. It's like uncasing a sausage to get a full release. So you get the thin little web in the front, but you've missed the back part that really inhibits the lift of the tongue. Not saying every provider with scissors is going to do that. I watched him do many beautiful scissor releases through his course. But with the CO2 laser, the benefits I see, as I'm lasering, it's like erasing, and I can see what I cut before I cut. Sometimes there's blood vessels that run up the middle of the frenulum. Sometimes you want to be, you want to hit little tiny things versus scissors. Where you cut, it's gone.
So with a master with scissors, I would agree. They have seen so many; they're very good. But I would still venture to say it is a blind technique because you have to go through the tissue and you're going through multiple layers of tissue all at once. Yes, they can spread it. They can do different things with it. With a laser, you literally are seeing every single layer. It's like peeling an onion layer by layer by layer. My other issue that I have is, and I learned this when I was in Italy and I went to a laser symposium, and they actually showed it was incredible. They took this test and they did it on sheep, and they took these sheep and they took the dermis of a sheep, they sheared them, and the dermis of a sheep and the dermis of a human is very similar. And they took about a silver dollar size amount of dermis off 3 different sheep, and they compared scalpel to laser. And they removed that, and then they wanted to see what the healing would be like in comparison, just CO2 laser to the scalpel. So I had used scalpels all the time up until this time, and then until I saw the difference. What I saw was with the scalpel, what happened is that the tissue would heal, but you would not get traditional tissue. It was a much tighter tissue. The scarring was not normal tissue. There was no sebaceous glands. There was no hair follicles. It did not have the normal cell matrix that you have in traditional skin. And it's not as strong of an area. With the laser, it grew back with sebaceous glands, that's sweat glands, hair follicles, traditional epidermis and dermis. And I was going, oh my gosh, there is a huge difference between the two. So to have a group come out and say, I don't see any efficacy, well, I can show you efficacy. And
so why is that? What happens with the CO2?
What's the science behind it? Mm-hmm. I think it's because literally with a scissor, we are doing a tremendous amount of more damage than cellularly than you are with the laser. Mm-hmm. The laser, it is layer by layer by layer. So you're not going in and ripping an entire. We have no idea how much damage there is from the actual blades of that scissor in comparison to a microscopic amount of energy.
A wavelength.
Yeah. So that's what I think is the difference. Mm-hmm. So it's the
mechanical kind of versus that.
Exactly.
Where with the CO2, it feels like you just really evaporate.
And so what I've noticed with patients, I don't use scalpels anymore for my traditional surgeries. And so what I've noticed, and this is anecdotal because I'm not going to do a bunch of studies on it, but the amount of pain patients have from using now that we have switched has gone down dramatically So the morbidity, what the patients are actually feeling, has dramatically decreased.
Mm-hmm.
And I'm going, I'm never using a scalpel again.
Yeah.
So yes, a baby cannot give us that anecdotal evidence,
Right.
but what we see is that the babies really heal fast.
Yeah.
The scarring is much less. That's why you use it, correct?
Oh yeah. It's safe. There's not as much heat. There's no heat like you have with a diode. So it's just it's a beautiful laser. And it's a beautiful tool to
So
have.
the crazy thing is most of the article we agree with.
Yeah, absolutely. I mean, from what I've kind of looked over, I agree that like the evidence, right? Like evidence-based, scientific, and what I've learned in lots of different courses is you have to remember what it takes to have a double-blind, evidence-based, like these research projects that are set up. This is not, okay, you get a placebo drug and you don't,
Well, first of all,
right?
how are they going to do a double-blind test with babies, newborns?
Yeah,
That's just not going to happen.
it's just how would you do it? So, and Dr. Kahiri in his course said it was either jumping off a building or a bridge or something. He said, is it, like, do we need evidence to know that this is like a good idea or a bad idea? There's just some things when the tongue is held down that much. I mean,
So the one thing I would say, we know that there's some tongue tie, I don't know, factories out there that's all they do.
absolutely. And
And
every baby is coming through, getting 4 sites done, no
every
matter
single
what,
time.
every single time.
And so, and I know this, but you routinely turn babies away.
Absolutely. And I give options. So, you need to do a consult. You need to explain to parents what you see so they can see it. And for the most part, after I show them the inability of the tongue to lift, the tension, they understand it. And I'm putting those pieces on the table for them to put together to feel good about doing the procedure. So, you've got lactation that they've seen. Maybe they've seen a functional medicine doctor, which we see a lot that look at tongue ties. Body workers, chiropractors. They've had different assessments, and we're bringing all those pieces together to say, okay, maybe this really is due to this restriction, versus every baby just gets released right away. And there's some I'm really, sometimes I'm on the fence about. I'm like, they have too much body tension. That might be contributing. We send them away for body work. And that happens, that's pretty frequent. If they don't have a lactation specialist who can help them through this process.
Who does the body work?
So we work with craniosacral therapists. We work with chiropractors. We work with PTs.
Have you seen improvements with the babies just from the body work?
Oh, absolutely. I'll see a baby where I can barely even get in their mouth. I'll take a picture to try to get, the tongue tie. The bright red tension, blanching through here, blanching on the lips. And that is not a baby that you release. So that is a baby that needs some body work, some intraoral mouth work, before you ever think about doing a release. If you release on a baby that tight, they're not going to heal right. Parents aren't going to, if I can't get in there to even take a picture, how are they going to get in there to stretch? So, no, body work, it can, on some babies, is really important. If they're really bound up, if they have torticollis, stuff like that, you got to address that as well.
What's torticollis?
Just any time. So when they're a little kind of, if I see them on the table and they're a little kind of kinked like that, or that, from being in the birth canal. And we always ask about the birth story. Was a long labor, just all those different things. So a lot goes into your assessment and what has happened. For baby, for mom, birth. If you're just showing up and, okay, hurry and laser, we can do this in 5 minutes. That's not a thorough assessment. And that probably happens a lot. With, the use of CO2 and people just doing it in their office. versus taking their time to consult and just saying, "Oh, yep, you have a tongue tie. Well, let's go do it."
So why do you think, I mean, baby tongue ties have been in the media um, recently. What do you think's happening? What's going on? What is it? Is it that airway focused medicine is finally arrived to some degree? Is that we're getting more adverse reactions because it's being done so much by unqualified individuals? Is it a combination of a lot of different
It's
things?
probably a combination. So I think Airway's becoming a bigger thing and people are understanding it, and women want to breastfeed more.
And be more
So
natural. And it's
yeah,
yep. What's
absolutely.
the average American woman breastfeeds for how long in the United States? I heard this statistic. Let's see if you have the same statistic that I've heard. You know,
No, I don't know.
I've heard 6 weeks. The average American woman breastfeeds for 6 weeks. Now we know that there's some that just it's not going to
Right.
happen. So we
Right.
don't want to make anybody feel bad. But if you look at if you said ultimate for the best for the child and you could breastfeed, what would be the average that you should try to breastfeed for?
Well, the AAP recommends, like 6 months. So that 5 to 6 month mark, you want to be getting those antibodies, and that's what they recommend. So they do acknowledge that having a tongue tie can affect that. It can help with nipple pain. There's not a lot in the article that talks about really how the tongue tie can affect breastfeeding. Other studies have been done in other countries about how helpful it is with breastfeeding.
So here's the hard part though. There is a window that is best for the child. Like there is a window that and so with the AAP, they're like, okay, you need to exhaust all these things prior to getting a tongue tie, which we would say absolutely,
Mhm.
you need to do as much as you possibly can.
Yeah.
But if you said this is the window that works best for children, for newborns, to be able to see in between this and this, what are those? What's that time frame?
I don't think you can put really a time frame on it because
Because
every baby is so different.
when would you like to see the baby though? If they truly had a problem.
So I think everyone should be seen right away. I was seen day 3. I mean, I didn't have much help in the hospital, which I get it. They have a ton of patients. It's difficult in a hospital setting. That's why private lactation consultants are really important. Um, without
Does
them,
medical insurance pay for that?
some do, some don't. Mine didn't.
Hmm.
So, which is unfortunate. Everyone's should. But, if I didn't have that, I mean, really, day 3 of life set up visit, I wouldn't have known he was not transferring. They did the weighted feeds. They got me back on track and getting by, right? So we had my support team. We started chiro. We started, he had a lot of body tension. So that's just what he had to deal with. And I ended up releasing him at 3 weeks old. I wouldn't have done anything differently. So for his story, that made sense for how much body work I felt like he needed to do. And we went from not breastfeeding and really struggling, nipple shield. I was trying to put him on, and it was just an awful experience for me, for him. He just hated it, to exclusively breastfeeding within a few weeks after the release. So, all those, not saying the tongue tie alone like did it, but the body work, like everything came together. And
You needed it all.
We did all
You
we
needed it
needed
all.
it all. We did all the things. That was the last step. And then we rehabbed with lactation to try to get him to function, because he had really low tongue function as well. He didn't have a great suck. He struggled. We had to do a lot of exercising to get him there.
That brings up a good point. If someone, again, across the country, they were looking at it and they're like, okay, they found a lactation consultant, they went in. If you went in, one of the telltale signs is who's in your team that helps you with. So let's say you're the provider that did the tongue tie release. If they don't have a team of support around them, you should probably be looking for another
Yeah, you should have
provider.
there should be a village that they work with routinely of providers, I would say, on average, that they know, okay, the baby has a low-lying tongue. We have a tone issue. Maybe we need to work with PT. Like, we routinely have our providers that we were teammates on. So, I think that is always helpful. As far as, waiting, mom's milk supply changes around that 3-month mark. It's really important to have that baby learning how to suck versus compensating and chomp, and maybe mom's supply is compensating for the baby. So I would say with lactation, they report that generally around that 3-month mark is when they see things turn south if we have feeding issues and functional issues at the breast.
So it is, I've done surgery my whole life, and you have now taken over all of that for my practice. You have taken it to a whole new level. You're better at it than I am. You really are. You are absolutely fantastic. But is there anything more nerve-wracking than working on a little
No,
one?
they're precious. That's why, none of us, any of the providers out there, Dr. Pinto here, Zoggy, no one wants to do an unnecessary procedure on a baby. And this is not, I guess some can be quick, easy, they, in those other articles have made it sound really bad. But for the most part, like every educator out there, they educate on the normalcies. You take your time, you're working on a precious little baby and you take it really, really serious. I mean, I've worked on kids for years and years, and I love treating children the same, like, loving feeling. But you're taking this brand new baby and hoping to give them a better outcome, and it's a serious no joke deal.
Yeah.
And maybe it looks easy on videos, right? You see a video of a tongue tie, maybe people think, oh, it's just so quick and easy. And it is quick, but it needs to be precise. And it's everything that encompasses, right? Our appointments are an hour long, and I'm back there doing the procedure no longer than 5 minutes at the most, with taking photos and then the procedure. So it's all of the assessment, and it's learning the babies, learning what a tone of a tongue it means, if it's a lying tongue tone issue, or if it's a tightness with the body. So there's a lot to look into and assess, even though that might not be I'm not a chiropractor, I'm not a PT, but I can see those things just like lactation can. They're not going to diagnose a tongue tie, but they can see the warning signs and why they might need to
Well,
refer.
just like an orthopedic surgeon that does knees every day, he's not going to do every knee surgery that comes in. He's going to evaluate. They're going to
Right.
see what, and he has a whole team of experts before and after that is going to make sure that that is going to be the very best.
Mm-hmm.
We do have a window that is best for the children. I mean, we don't. It's really hard to work on a 6-month-old. And
It is very hard.
I mean, it's.
I will say it's much easier for everyone, parents, the post-op stress, everything, when they're younger.
Yes.
Like within that first month.
Yes.
I'd say it's
I mean,
significantly
10
easier.
weeks is a huge difference than a 3-week-old. Like your son.
Yeah.
That is a doable, much easier to manage. When I first got into it, the youngest I've done is a granddaughter that was 3 days old.
Mm-hmm.
Now looking back, that probably was a little young, but it was still, and yeah, I would still do a grandchild. But it's boy, is that a nerve-wracking. I mean, your heart is going a million miles an hour. You're looking and you're making sure that everything is perfect. And these little ones don't, I mean, especially when they start getting into the 12 weeks, 16 weeks, now they're getting strong.
They're strong. They're gonna fight you more. They're gonna cry more. It's, I had a really good experience with my son. I thought there was one time that I thought he was maybe uncomfortable, that I did some homeopathics, but that was really it. But you do get a little bit older, they're just gonna be fussier.
We had before I turned it all over to you, we had a patient that I will never forget. The lactation consultant had called me and asked me to see this one patient that was kind of special. And I was like, okay, what's going on? Well, this family was in the news. And what happened is that the baby had a failure to thrive. Can you explain what a failure to thrive is?
So, I mean, we look at it's the weight gain. And that's what they're looking at. And that's why you go into your pediatrician, soon after birth, they check weight, jaundice, like that's what they're worried about, weight gain.
Yeah. And so this baby just was not thriving. It was losing weight. And so the state came in and took the baby.
I can't even imagine.
Can you imagine?
No, I would lose.
I
would absolutely lose my mind. I'd be a psycho.
First of all, John would be out there making sure that no one in hell would touch his baby. It would be a full-on armament.
I would probably go to prison. I don't know. I would lose my mind.
They took the baby.
Yeah, that would just.
They took the baby. It was all over the news. There was neighbors that were fighting it. I mean, and so they met with the lactation consultant. They're like, "This is you have a horrible tongue tie." And the baby just would not feed, wouldn't take a bottle even. They did everything. The parents did everything they could. And then the state takes them away, still was not thriving, gives the baby back for a short period of time and said, we're going to come back. And if you do not get weight, we're going to take them basically for good.
At least that's shocking that even happened.
I know. And well, there's a lot of political things that happened around that. And okay, this is what I know, but I'm not sure about it. And maybe I didn't hear it correctly, so don't take all of this. But my understanding is, and the agency, whatever that agency is, they have a quota of how many babies they have to take.
Oh, that's terrible.
Horrible.
That's horrible.
And so they were worried that maybe this was, anyways, to make the long story short, they bring the baby in.
Because they've been taking him into lactation and trying. Showing effort.
Yes.
Yeah.
So, like you said, these lactation consultants, now I just want the public to understand, they do not get paid to show up at a surgery, to come in and be able to be there with the mothers. And I mean, think of all that they do.
They just love the babies.
They do.
They just want to be there to help. They're a wonderful group of people.
So the lactation consultant comes in. They accompany the parents. I had the mother, the father, grandpa, I mean, they had a whole village waiting in the waiting room.
Yeah.
And they were just hopeful that something would help the baby to be able to feed. So it's a tense situation. We do not allow parents in the room because I don't and you don't. We don't want to have to worry because we want to focus 100%.
100%. Yeah.
Now, the lactation consultant, we welcome. Please come in. So we bring them in. We said a little prayer for the baby. We do the tongue tie release. I had the lactation consultant I looked at it like just to make sure there was nothing left.
Yeah.
If we're going to do it, I want to make sure it was right. But it's really fast, done, over with. And then you're just thinking, I will never see this baby again.
Yeah.
The baby leaves. And I think it was a week or 2 weeks later, the baby is just absolutely thriving.
Yeah, you're going to make me cry. I'm pregnant. I'm going to make me cry. Like, it's just like the best story ever.
Yeah.
It's the best story. I mean,
it was thriving. The parents wrote me this beautiful thank you.
And I don't know what the tie looked like. I mean, but there are some that are shocking that you're like, I can't believe it really was holding up that much function. Some are surprising and they are hard to diagnose. And maybe it was one of those where you're like, yeah, that just really where it was positioned held the tongue up that much and the baby couldn't compensate. And
so
it's
I don't even care if some government agency said that this is absolutely unnecessary, which is AAP is not saying that. I get that.
They're saying
I think it's just a warning, and which we agree.
And that's what we preach. Be careful.
Yes.
Go make sure your providers do everything we talked about at the lactation conference, where we encourage lactation specialists to go get to know your referring provider. Do they have a room where the mothers can feed? Do they do a consult? Do they allow parents to discuss in private? Do they encourage them to come back another day? Take your time to think about it. Like, know who you are referring to instead of, oh, yeah, we just take them back and clip everything.
Yeah. Yeah. Well, my dentist said that they just took a course and that they can do this. And I think you don't be that first patient.
Yeah. Who are you trained? Who's your provider trained under?
Right.
Look into those people who are training.
I watched a YouTube video and stayed at a Holiday Inn, so I'm ready to go.
Right. Because anyone can go buy a laser.
Because it looks.
And go do it tomorrow.
When you go to these conferences, you got to realize that as a provider, you go to the conferences, a lot of times they're being sponsored by people that are trying to sell you the equipment. Sometimes it's a laser company, I'll be honest. And they just make it look like, hey, this is a piece of cake, and that it doesn't take a lot.
And that's everything.
It doesn't matter.
It doesn't matter what industry.
Oh, no, that's medicine.
Here's an implant.
Exactly.
Seeing, done.
Yeah.
Well, we know it's more complicated than that.
I mean, here's a laser, go suck fat out of people. I mean, they make it look so easy. And here, spend this money and you're going to be able to, and here's your return on investment, and you're going to get all these patients. So and I understand it. I do. But again, I am a dentist, and I did get a laser for a lot of different reasons, and we incorporated it. But I saw a problem with me, and that problem was that I didn't have the time to really connect with the parents. This is something that you and your team does better than I have ever seen, including Pinto, including anyone. I'm dead serious. Because I see you go in and you connect with the mothers. You are part of them. It is incredible with what you do. And if you are a mother, if you're a parent, you have got to come in and see this team, because I'm telling you, it's the very best I've ever seen.
Well, I think what we do a good job with is showing parents with the feeding assessment so they can make an informed consent decision. That was a huge part of my lecture as well. I want them to, here's all the information, and you should know enough that you can feel good about the decision you're making. Here's what we see, I'm showing you, and now you can decide. Versus saying, oh yeah, they have a tongue tie. Would you like to do it?
Yeah, right? and we have parents that come in. They come in and they are expecting to do a tongue tie that day. You sit down with them. You tell them they have a tongue tie, and they're questioning it. And I've seen you. You're like, it does not need to be done today. No. Go home. Think about
it. Because I want them to feel how I felt when I decided to do my sons. Because I drove myself nuts for weeks, and I was going to all my therapists, and I'm like, I know I should release him. I should do it but is it necessary? His tongue is up sometimes it's down. It's, we had other things going on, and I was just driving myself nuts. And then on top of like, you're a new mom, but this is what I do for a living, and I should know this. And even though I had, other providers look, I still needed to know for me. Like, I needed that confirmation. And so when I finally looked at it and assessed it in a certain way after the bodywork, I'm like, this is maybe that I didn't feel this way 3 days ago, but now I do today. So if they need to go take a couple of days to think, process the information, great, right? So there's one thing to just tell people, well, they have a tongue tie, you got to go get it clipped. I mean, that just doesn't. You've got to educate on what it is, what's normal, why is it impacting breastfeeding? And that's where the lactation specialist and everyone is really important coming into play.
I would tell a parent, trust your gut.
Absolutely.
Trust your gut. Yeah. If you listen to the experts.
Yeah.
And if you feel it's necessary, and after you've heard all of the evidence, then make that informed decision.
Yep.
But trust your gut. If it does not feel right,
don't do it.
Get out.
It doesn't even matter if it's the most obvious tongue tie in the world. If it doesn't feel right today, maybe it will next week. or in 2 weeks, or go do some more body work and keep doing your thing. And we're here for you. So
Exactly.
that's where it takes a lot more time and visits with parents when it comes to doing tongue-tied consults. And maybe that's the part that gets really overlooked, right? It's just the procedure versus how important these consults and assessments are. And if those were done more, you're looking at body work, you're looking into different things, it wouldn't be maybe overdiagnosed as much.
Well, I think you said it right. The consultation is the treatment.
Yes.
The
Yeah.
treatment is 15 seconds.
It's very, very quick.
It's very quick.
Yes.
And so that's where you're getting all of these popping up, looking at only the 15 seconds. What they're
Right.
not seeing is the hour, the consultation, the talking, for the parents to understand. That is the treatment.
Right.
Because it's so much more important. It's the team, it's the group that's all around you, it's everything. You have baby number 2 coming.
Yep, I have baby number 2 coming, so we'll see. We'll see if they have a tongue tie. Who knows?
When are you due?
November 9th.
November 9th.
Yeah. But again, I'm going to go see Lactation
What's your
again beforehand
You still have fear
to go get a little refresher course.
because you're still going to go through all of this.
Yeah, I need to go. I want to learn again. Okay, what are some things? I'm going to have Lactation come day 3. I don't even know. Maybe he'll be a breastfeeding champ. I don't know. But I think
It's a he.
Yes, it's a he. So important. I tell anyone who's having a baby, I'm like, go find a lactation consultant before you have your baby and just have that in place. Even if it's one visit where they do a weighted feed and they're like, yep, they're transferring, it's going well. I mean, that peace of mind is huge. And trying to scramble to find someone and who do we go to, that's someone you want to meet with, who that's a really close relationship that is really helpful to have ahead of time versus when we're in crisis mode. And now we've lost weight and what do we do? And the pediatrician's telling us to do this or that, or, have everyone game plans and talks about your birthing plan, which is completely unpredictable. And a lot of emphasis is put into that part of birth, but it's the what after. And
Yeah.
feeding your baby is number 1.
Yeah, it's huge.
It's huge. And lots of people have issues and lots of people need support. And it's, there's been some videos that have come out talking about how breastfeeding is just natural and women shouldn't, lactation specialists shouldn't even be a thing, which is just
Ridiculous.
the most ridiculous, shocking thing. It should be part of what we do. And as a support to women, we talk about postpartum depression and all these things we go through after birth. If you can't feed your baby, if you're not, we don't need evidence to tell us that that's a problem and that's going to lead to some mental health issues. And, you're not sleeping, you can't feed your baby, they're crying, it's a lot.
Yeah,
so,
but there's also people saying that just take coconut and swish it through your teeth and it will take care of that root canal and that abscess that you have. So, it's like you hear everything, but congratulations on baby number 2. I remember having our second son and I remember the fear I had. There is no way I'm going to love number 2 as much as I love number 1.
You worry about and think that all the time. Like, I have this perfect angel. Like,
yes.
I feel bad. Like,
there's no way I can love number 2 because the amount of love that comes from this, there's just no way.
Like, how can you duplicate it?
Right.
Yeah.
Which do you love more, your son or John?
Oh, come on. That's a mean thing to say. We all have our kid. Your kid, you know what? John always says this, though. He'll say, kids, no matter what, are in a category of their own. They can't be placed with anything else. Kids are just always in their own little special universe.
That's a got me question because I think there's a romantic love and then there's a protective love. You would leave. Any mother is going to leave if they had to pick between the two. They're picking their children.
Well,
It's
you've
just
heard like your brain changes.
Oh,
So
yeah.
you have changes inside of you that you turn into a mom, and there is just nothing that is going to come between you and your
Have
baby.
you ever heard of so Hiram Smith talks about um, the priorities in your life. And he did Franklin Covey, the whole deal. And he talks about the I-beam. Have you ever heard of that? Okay, so the I-beam scenario. Let's do the I-beam scenario. Okay. All right. So here's the I-beam scenario. We are, and I think I did this on another one. I can't remember. Did I, Nate? Oh, I don't remember this. Okay. Anyways. Okay. So this is really interesting. The I-beam scenario is this. I have a 120-foot I-beam. Do you know what I-beam is?
No.
I-beam is used in construction. It's about 6 inches tall,
Okay.
and they use it in steel construction for big buildings.
Okay.
It's about 6 to 8 inches tall, and it looks like an eye. If you look at the cross section, it looks like an eye. So it's steel. It's 120 feet long. And this I-beam, or roughly, let's just say it's 120 feet long. If you turn it on its side, it'd be an H-beam, but we're going to be on the I-beam. So it's about 4 inches is the top of the I-beam. We're going to put it in the parking lot out here, and I'm going to put you on one side, and I'm going to be on the other. Okay, got it?
Okay.
And I'm going to say, Chelsea, I have $100. If you step across the I-beam right now, I will give you $100. It's just on the ground. But if you step off to the right or to the left and you fall off the I-beam, you don't get the money. Would you at least try?
Of course.
Yeah. For $100?
But absolutely.
Yeah. Okay.
Eyes closed. Okay.
Yeah. So we're going to change it. I'm going to put the I-beam now and on a barge, and I'm going to take it to the Philippines. And I don't remember the towers. It used to be the New York, the World Trade Center towers.
Yeah.
Okay. But we have to change it to the largest towers in the world, which is even higher than the World Trade Center. The World Trade Center was 100, I think it was 110 stories, but the one in the Philippines is like 130 stories. We're going to take it to the very top of the towers, and we are going to bolt the I-beam to one side and the other. I'm going to put you on one side. I'm going to be on the other, and it's bolted down, but there's a bend because it's so far.
Okay.
Okay. Now, up there, it's about 40-mile-an-hour winds. We just happen to get that it's going at the same frequency. Okay. So we're going, and there's this I-beam. You're on one side, I'm on the other, and I say, Chelsea, I've got $100. If you come across this I-beam and you don't step off to the right or to the left, I'm going to give you $100.
No.
No way.
No thanks, Lon.
Okay, we're going to change it. Okay. I've got $1 million tax-free. Here's $1 million tax-free. You just have to step across the I-beam.
Maybe back when I had better balance. Right now, I'd probably say no.
Would you? Okay, no. All right. One more time. I've got $1 billion. It will change generational. $1 billion tax-free. It is, by the way, right now it's raining just a little bit. So it's just raining, a little bit more windy. Are you going to do it?
No. Depends on me, maybe 10 years ago, 15
No, right
years ago.
now. You're
right
pregnant,
now,
everything.
No, I'm not doing it. I'm not doing anything.
Okay. Whole new
There's
scenario.
no amount of money. There's no amount of, right? I would never risk leaving my son and, yeah.
Whole new scenario.
Yeah.
I'm now not Mr. Nice Guy.
Okay.
You are on the one side. I'm on the other. I have Wilder by the head, and I'm dangling his entire body over the building. And I say, if you don't come over here right now, I'm dropping him.
Yeah, I'm leaping.
Without even a thought, right?
Probably running. Yes.
You're not even going to think about it.
No, there is nothing you wouldn't do. There's nothing.
So Hiram Smith says, what are the things are you willing to go across the I-beam for?
Yeah.
And do we spend our time with those things?
Well,
isn't that interesting?
It is interesting.
And so that's the I-beam scenario of what is the most important in your life. What are you willing to cross it for? Are you willing to cross it for money? Are you willing to cross it for power? Are you willing? No, none of those things are important.
Right.
But yet we put a lot of time sometimes where we shouldn't.
Yeah, absolutely. You have to always keep perspective of what's the most important, and it's your little ones.
Absolutely. It's your family. It's where that's where life is.
And that's an important part of what I feel is really rewarding in what we do is we're a piece that we give, just like you with that family. Um, we can be there during some really important times in people's life and be a support, because I mean we feel it. You and I value family and kids. They're the greatest. So
Well,
we love being there for the families.
we see these families come in, and we have their most precious gift
Yeah,
and given to us, and we take that very, very seriously.
very seriously. Yep.
Well, thank you, Chelsea.
Yeah.
Until next time.
Thank you. Until next time.
Okay.